Thank you very much for the invitation to give this presentation about outcomes after NUC therapy discontinuation in this excellent and exciting symposium. This is my disclosure slide. Now, first, I would like to bother you with the life cycle of HBV to understand why NUC therapy does not usually lead to an HBV cure, and that we need to talk about discontinuation of HBV therapy before HBs antigen loss. NUC therapy does only affect here the viral replication, but has a minor effect on the cccDNA. Thus, viral proteins such as HBs antigen is still released due to active cccDNA, transcriptional active cccDNA, and also due to integration. And thus, if we treat our patients with NUC therapy, we have a profound effect on HBV DNA, but only a minor effect on HBs antigen. And it takes quite a while until HBs antigen is negative. So usually it takes more than 50 years. It can be much faster, maybe due to some immune responses, but it can also take more than 100 years. And HBs antigen loss, as also defined now as functional cure, is the endpoint of therapy. And in that case, NUC therapy can safely be discontinued. However, recently, there's an emerging interest of stopping NUC therapy before HBs antigen loss. And many of the data coming from Asia, because they have already implemented years ago stopping rules due to economic reasons. But we have also seen interesting data on HBs antigen loss. So there are in fact two different concepts when we talk about stopping NUC therapy. One concept is that we want to maintain biological and clinical remission in the patients. And the other interesting concept, which emerged more recently, is that we see data that after stopping therapy, HBs antigen loss, so functional cure, is more prevalent in those patients. Now, first, I would like to talk about the concept stopping NUC therapy and maintain virological and clinical remission. I would like to start also with a trial here from Asia. And you can see this stopping concept here, that patients with e-antigen negative hepatitis have been stopped if there was 3 times HBV DNA negativity more than 6 months apart. And we have seen many trials from Asia showing similar results. So after stopping, usually there is a biological relapse and also clinical relapse as displayed here, but only in a proportion of patients. In this case, in 45%, we see clinical relapse after stopping therapy. So there are some patients that remain into remission after stopping treatment. And usually the consolidation therapy is important. So patients that have been treated longer times are more likely to remain in biological remission. Also, when we talk about outcomes after stopping NUC therapy, we have to talk about flares. And if there is virological relapse, there can be also clinical flares. And in fact, if there's a flare in a cirrhotic patient, that can lead to decompensation. In fact, this has been shown in several of these trials. And therefore, we need to take care of this issue. And therefore, the EASL guidelines only suggest stopping therapy in non-cirrhotic patients. Now, this is a systematic review about stopping NUC therapies. And I would like to focus here also in my talk on e-antigen negative patients. And overall, we see that around 30% maintain into biological remission after stopping NUC therapy. There's a difference in e-antigen positive patient, but this is a topic in itself, because in e-antigen positive patient, we have the issue of seroconversion, but after stopping NUC therapy in those patients, there can be also more severe flares and so on. So I think this is something maybe for the discussion. Now, if we talk about stopping NUC therapy, we also would like to know which patients benefits from those concepts. And we could maybe stratify those patients for stop NUC concepts. And one predictor for biological remission after stopping NUC therapies is low HBs antigen. This is associated with maintained HBV DNA suppression after stopping NUC therapies, shown by several studies. This is just a few examples of the studies that have demonstrated this issue. Sometimes the cutoffs are lower than 1,000, sometimes lower than 100. Lower, the better. But don't forget, HBs antigen can also be derived from integration. And so also patients with higher S antigen levels, maybe all from integration, maybe benefit from stopping NUC therapy. And there's a question also from emerging markers like HBV RNA or correlated antigen. And there have been some recent studies documenting that also these markers could distinguish patients that benefit from stopping NUCs or not. But so far, these markers are not routine diagnostics. So I think this is still ongoing debate, and we need more data on this issue. Now, what does it mean in the end if we have, for example, low HBs antigen or low HBV RNA or low correlated antigen? And I think this may also indicate some level of immune control in those patients. And in fact, it has been shown by Carolina Boni and Carlo Ferrari that there is some restoration of HBV-specific T cells after long-term effective therapy with nucleoside analogs. And this could lead and explain why the longer treatment is associated with less relapse, that we have kind of an immune control already ongoing, and this may prevent relapse. And in fact, a nice paper from Antonio Bertoletti's group has shown in a Stop NUC study that HBV-specific T cells are associated with viral control upon NUC therapy discontinuation, a specific T cell population. This is very interesting and suggests that we also need to look to host immune marker and not only to viral markers when we want to stratify our patients. Cellular immune response is, of course, challenging to implement into routine diagnostics, but what about soluble immune markers like cytokines or chemokines? And this is our work. We have recently been published. We have looked for soluble immune markers like cytokines or chemokines in patients who stopped treatment. And not a single cytokine or chemokine could predict relapse. However, a mix of 5 cytokines could predict relapse, which was identified by a machine learning approach. So I think in the future, we need to combine different kinds of patterns and maybe use modern technology like artificial intelligence to help to predict relapse or outcomes after stopping NUC therapy. And these modern technologies maybe could identify novel markers. Now, also one issue we need to consider when we talk about stopping NUC therapy is that we may see different patterns of virological relapse if we stop tenofovir or entecavir treatment. And this has been shown in several publications or ILC abstracts, and recently also shown by an international consortium of different investigators putting all data together. And here we confirmed in this multi-center trial led by the Toronto group in 1,420 patients that there is a faster relapse after tenofovir stop compared to entecavir stop. However, in the end, there's not much of a difference in the long term. But it is important, I think, to know this, to monitor the patients after stopping NUC therapy. And also maybe this could have maybe an impact later on also on other outcomes. We have to see. Now coming to the second concept, which is inducing HBs antigen loss after stopping NUC therapy. And in fact, many studies have now shown, and here I just highlight the European studies, I come back to this in the Asian populations, that there is obviously a higher rate of HBs antigen loss after stopping NUC therapy. So up to 39%, and this is kind of interesting. And this we do not see on maintenance NUC therapy. In fact, the best would be to have a randomized controlled trial. And the largest randomized trial to date on stopping NUC therapy is from Germany, presented by Florian van Bemmel and Thomas Berg at the ILC 2020. And there's a randomized trial, discontinuation versus continuation in 160 patients. And you can see, just focusing here on HBs antigen, that there is some noise here and more patients show a decline of HBs antigen levels compared to continuation of NUC therapy. And in fact, 10% show an HBs antigen loss. And the HBs antigen loss, again, was higher in those patients with lower HBs antigen levels. In fact, here, lower than 1,000. And here we see 28% HBs antigen loss. So in selected patients, well-selected patients, we see high rates of HBs antigen loss. This is important also for the design of novel concepts and randomized trials in the future dealing with HBs antigen loss. Now, what is the reason for this? And the rationale and the reason for HBs antigen loss? And one idea, of course, is that there's some induction of immune responses induced, for example, by the relapse, not only of HBV DNA, but also on relapse of proteins like correlated antigen and so forth. In fact, our group has shown that in our Stop NUC study, there is an induction of several cytokines suggesting of immune alteration. We see a different responsiveness of T cells after stopping NUC therapy in some patients, and also an induction of NK cell responses. This was even associated with ALT and also HBs antigen decline. So I think there is some evidence that we have an alteration, an induction of immune responses after stopping NUC therapy. Do we see similar data from Asia? In fact, yes, here in e-antigen negative patient. This is an example again from Asia. And the incidence of HBs seroclearance after stopping NUCs was higher than that during therapy. The 6-year cumulative incidence was 13%. So it looks like a bit lower than in the European studies. That depends always on the patient populations. But also in their study, they already suggest that this transient untreated clinical relapse may drive sufficient immune control to functional cure. In fact, this is very interesting, I guess. But we look also to some different cohorts, and this is the Toronto Stop NUC study. And in fact, in their study, they showed only a few patients lost HBs antigen. However, this was mainly e-antigen positive, or part of this was e-antigen positive patients, and most patients were Asian patients. So this already suggests maybe we see different patterns in different kinds of population. And in fact, again, data from the international consortium and shown also on an abstract, and now I think this paper is now accepted in gastroenterology, showed that there is a difference in the cohort here on Asian patient on HBs antigen loss and so-called white patients, or European patient, Caucasian patients that showed higher rates of HBs antigen loss. I think we need to consider these issues for the future. I would like to summarize and conclude my talk. Discontinuation of NUC therapy before HBs antigen loss is possible in selected patients, ideally more than 3 years HBV DNA negative, no cirrhosis. Viral control after discontinuation of NUC therapy is possible in a substantial proportion of patients, depending on duration of therapy, viral and host factors. Different relapse patterns after discontinuation of tenofovir or Antigen have to be considered. HBs antigen loss is another possible outcome after stopping NUC therapy. The mechanism is not completely clear, but it's probably related to immune mechanisms. Several aspects remain unclear and should further be investigated. For example, difference between the Asian and European cohorts, the tenofovir and Antigen, the e-antigen positive versus e-antigen negative, and the beneficial versus harmful flares. So I think there is also an interesting observation. Some discuss that HBs antigen loss is actually higher in those who do not flare. However, the flares can be very transient and have been missed in the cohorts. So I think this is an important issue for the future. And with this, I would like to end my talk. And thanks for your attention.